Alright everyone, welcome back. Today, we're covering one of the most important and high-yield topics in cardiology, heart failure. We'll talk about how to recognize it, the differences between reduced and preserved ejection fraction, the pathophysiology behind decompensation, and how to manage these patients step by step. Let's start with the clinical picture of heart failure. Patients often present with dyspnea, fatigue, and fluid overload. Among the clinical signs, dyspnea has high sensitivity but low specificity, meaning it's common, but not diagnostic by itself. An elevated BNP, that's brain natriuretic peptide over 100, is both sensitive and moderately specific for heart failure. Signs like orthopnea and an S3 gallop are more specific findings. Remember this for your exams. If you hear an S3, that low-frequency sound right after S2, think increased LV filling pressures and systolic dysfunction. Now let's talk about heart failure with preserved ejection fraction, or HFpEF. This is a disease of diastolic dysfunction. The ventricle can contract normally, but it doesn't relax properly. So it fills poorly. The biggest risk factor here is chronic hypertension, which leads to concentric LV hypertrophy. Obesity and sedentary lifestyle also play major roles. They create low-grade inflammation and microvascular ischemia, which lead to fibrosis and stiffening of the ventricle. Other contributors include diabetes and coronary artery disease. Management focuses on addressing comorbidities and controlling volume. You can use loop diuretics for congestion and antihypertensives for afterload reduction. To improve outcomes, add SGLT2 inhibitors like dapagliflozin and mineralocorticoid receptor antagonists such as spironolactone. And don't forget exercise training and cardiac rehab. They reduce hospitalizations and improve quality of life. When patients present acutely, we call it decompensated heart failure. BNP levels will often be high, but can be falsely low in obese patients. Chest X-ray may or may not show cardiomegaly. In patients with long-standing hypertension, the ventricle may be thick but not dilated. Edema in these cases results from elevated venous pressures. If you hear a holosystolic murmur at the apex, think of secondary mitral regurgitation due to LV dilation. Now let's review what happens physiologically in systolic dysfunction. The failing ventricle can't pump effectively, so stroke volume and cardiac output fall. The body compensates by activating the sympathetic nervous system and the renin-angiotensin-aldosterone system. These mechanisms increase afterload and preload to maintain perfusion, but in the long run they actually make heart failure worse, a true vicious cycle. So you get volume overload, elevated central venous pressure, and renal congestion. The kidneys respond by retaining sodium and water, worsening the edema. Over time, the myocardium remodels and the ejection fraction drops even further. Let's zoom in on one key concept, the cardiorenal syndrome. This is when the failing heart leads to secondary kidney injury. Because of elevated venous pressure and reduced forward flow, the kidneys are both congested and underperfused, the perfect setup for prerenal acute kidney injury. Lab findings typically show elevated creatinine with a BUN to creatinine ratio over 20:1. Treatment: start with 4 loop diuretics like furosemide to relieve congestion and restore renal perfusion. A special exam finding to remember is the hepatojugular reflux. If pressing on the upper abdomen causes the jugular venous pressure to rise more than 3 centimeters and stay up, that's a positive test. It strongly suggests right-sided heart failure. Why? Because in RV failure, blood can't move forward, so abdominal compression sends more volume to an already full venous system. In contrast, you won't see this with isolated cirrhosis, since the IVC pressure isn't continuously transmitted. So, how do we manage acute decompensated heart failure? Step 1. Assess stability. If there's respiratory failure, start non-invasive positive pressure ventilation. If the patient is in cardiogenic shock with hypotension, start an inotrope like dobutamine. Step 2. Improve symptoms. Reduce preload with 4 loop diuretics and venodilators like nitroglycerin. If the blood pressure is high, you can also reduce afterload using nitroprusside. Step 3. Identify triggers: ischemia, arrhythmia, uncontrolled hypertension, or valve dysfunction. Get an ECG and echocardiogram to find the precipitant. Now, Let's review chronic medications for HFrEF, that's heart failure with reduced ejection fraction. There are 4 major drug classes that reduce mortality. 1. ACEi inhibitors or ARBs, or even better, angiotensin receptor, neprilysin inhibitors like sacubitril valsartan. 2. Beta blockers, specifically metoprolol, carvedilol, or bisoprolol. 3. Mineralocorticoid antagonists, spironolactone or eplerenone. 4. SGLT2 inhibitors, dapagliflozin or empagliflozin. Loop diuretics improve symptoms, but don't reduce mortality, and digoxin can reduce hospitalizations but not survival. Now, a quick note on prognostic markers. Hyponatremia in chronic heart failure is common and reflects advanced disease. When serum sodium drops below 130, 1-year survival can be as low as 15%. The mechanism is chronic ADH activation, leading to water retention. We treat with fluid restriction and sometimes tolvaptan, a vasopressin V2 receptor antagonist. Mildly elevated liver enzymes from congestion are common but not prognostic. And while electrolyte abnormalities like hypokalemia from diuretics are frequent, they don't independently predict outcomes, though they can trigger arrhythmias if severe. BNP deserves its own moment. BNP and NT-proBNP are released when ventricular wall stress increases. They help distinguish cardiac from non-cardiac causes of dyspnea. A normal BNP essentially rules out heart failure, while high levels correlate with disease severity. Also note, the presence of an S3 gallop often parallels BNP elevation. Next, let's discuss high-output heart failure, a very different physiology. Here, cardiac output is high, but the body's demand or vasodilation outpaces it. You'll see wide pulse pressure, warm extremities, and a hyperdynamic circulation. Common causes include morbid obesity, AV fistula, hyperthyroidism, severe anemia, cirrhosis, or Paget's disease. Over time, the LV dilates to handle increased venous return, and symptoms of HF appear despite high output. Speaking of AV fistulas, they decrease afterload and systemic vascular resistance, but increase preload and cardiac output. If the fistula is too large, the LV can't keep up, leading to high-output failure. Hyperthyroidism works similarly. It decreases SVR and increases both heart rate and contractility, resulting in a high pulse pressure and warm peripheries. During a thyroid storm, these effects are amplified, and pulmonary edema can develop despite high cardiac output. Let's shift gears to inotropes used in cardiogenic shock. Dobutamine is the go-to agent. It's a beta-1 agonist that increases contractility and heart rate, improving cardiac output and reducing LV and systolic volume. It also has mild beta-2 effects that slightly lower afterload. The result is improved perfusion and reduced congestion, though at the cost of increased oxygen demand. Now, a pearl on sacubitril, valsartan, the ARNI. This medication improves survival in HFrEF but can cause angioedema due to bradykinin accumulation. If you see swelling of the lips or face, stop it immediately and send the patient to the emergency department. It can progress rapidly. Next, COR Pulmonale, right heart failure due to pulmonary hypertension, not left-sided disease. It's caused by chronic lung diseases like COPD, interstitial lung disease, or sleep apnea. Patients complain of fatigue, exertional syncope, and abdominal fullness. On exam, you'll find elevated JVP, hepatomegaly, a loud P2, tricuspid regurgitation, and peripheral edema. Echocardiography shows RV hypertrophy in TR, and definitive diagnosis can be made by right heart catheterization showing a pulmonary artery systolic pressure over 25 millimeters of mercury. Finally, let's touch on infiltrative cardiomyopathies. Amyloidosis causes restrictive heart disease early and can later progress to dilated cardiomyopathy. You might see periorbital purpura, macroglossia, neuropathy, or nephrotic syndrome. Diagnosis is by biopsy, often of the abdominal fat pad or myocardium. Hemochromatosis, sarcoidosis, and Chagas disease are also causes of cardiomyopathy. Hemochromatosis adds diabetes and liver disease, sarcoidosis causes conduction defects, and Chagas leads to chronic myocarditis with dilated chambers and megacolon or megaesophagus. Let's summarize. Heart failure isn't a single disease, it's a spectrum of compensatory mechanisms gone wrong. In systolic failure, the heart can't pump. In diastolic failure, it can't fill. The kidneys, lungs, and vasculature all get involved, creating a cycle of congestion and remodeling. The mainstay of management is guideline-directed medical therapy, neurohormonal blockade with ACEi inhibitors, beta blockers, MRAs, and SGLT2 inhibitors, plus diuretics for symptom relief. And remember, BNP, S3, and hyponatremia are your high-yield diagnostic and prognostic clues. That wraps up our heart failure session. Take a deep breath, review those mechanisms, and let's continue mastering the cardiovascular system together.